Introduce our speakers today, starting with Dr. Heather Schmidt, a family physician at Fond du Lac Regional Clinic West. She's Medical Director of Health and Wellness for Ag Nation Healthcare. Dr. Schmidt also serves as co-facilitator for the Wisconsin Medical Society's Leading Healthy Work Systems Leadership Program. Dr. Matthew Dahl is a clinical psychologist who has practiced with St. Agnes Hospital since 1991. Of his many talents, he's trained in corporate consulting, specializing in team building and increasing work team productivity. Tamara Langoff is an advanced practice nurse practitioner with the Department of Family Medicine over at the Shepherd Center since 2016. Tamara completed her medical education from the University of Wisconsin-Madison in 1997. She's certified QPR, Question, Persuade, and Refer treatment trainer. She's also a member of the Prevent Suicide Greater Milwaukee and Prevent Suicide Fond du Lac Coalitions. Welcome, Tim.
Thank you all for coming. So these are our objectives for this afternoon. We're going to talk about understanding suicidal ideation, a framework for understanding that, and some evidence-based strategies for working with colleagues who may be suicidal. You're all, many of you are familiar with assessing patients in your practice who are suicidal and intervening, but today we're actually going to talk about what do we do when we're confronted with a colleague or possibly a friend who may be suicidal. And then the third objective, talking about strategies here at SSM, some system-wide initiatives and governance. Drs. Schmidt and Dahl will be talking about that at the end of our presentation. So first of all, the framework for understanding suicidal ideation. Well, why does this matter? Why do we care about preventing suicide? We know that nationally and in Wisconsin, suicide is the 10th leading cause of death for all ages. Now, in teenagers and young adults, I'm a pediatric nurse practitioner. It's the third leading cause of death for youth ages 15 to 24. But across all ages, it's the 10th leading cause of death. Data in 2011, there were over 8 million adults who reported suicidal ideation. This is what's been reported. This is just what's come to light. There were over 1 million people in 2011 who reported serious suicidal ideation to their care providers. And for each death by suicide, there were 11 million hospital visits, either inpatient or in the emergency department. So it's a huge public health problem. However, this was just what was reported. So what about the people that were in outpatient care or those who sought no care at all? And this data is published in The Burden of Suicide from 2007 to 2011. That's the most recent published data. There are new statistics that are coming along telling us more updated information. The cost of suicide, there's data called years of potential life lost. What that means is if someone died at the age of 18 and their life expectancy, say, would have been to 68, that's 50 years of potential life lost for that one person. So 50 years for one person. If you take that in the year, say, of 2007, and you multiply that 50 years times every person that died as an adult, that would be the years of life lost just in 2007. So for the 5 years from 2007 to 2011, there were 22,000 years of potential life lost to suicide in the state of Wisconsin. So that means that the productivity that we lost to suicide in 5 years was 22,000 years of potential life lost in the state of Wisconsin. So that's years of life lost at work, life of years lost in church participation, in civic activities, at your Elks clubs, in the community, in families. And suicide is the fourth leading cause of years of potential life loss after accidental injury, cancer, and heart disease. It caused more years of potential life loss than homicide, diabetes, and liver disease. And if you think about our evening news, we hear about homicide every single day in the news, and we don't hear about suicide. And there's reasons for that because, of course, there's copycats and those types of things, but it's a public health crisis. In terms of death by suicide, 4 out of 5 people that die by suicide are male, and 3 out of 5 people that attempt suicide are female. And I'll talk more about why that is. And the highest rates of suicide, as I look around the room, are middle white class males. There's a double peak in this data between the ages of 45 and 54 and over the age of 75. So middle class white males are the highest demographic for death by suicide. There are, of course, the costs that cannot be measured. And if you'll notice, I didn't present economic data because there are billions of dollars that suicide costs us every year. There's the healthcare costs, there are the work costs, there's economic costs, and really that's not what this talk is about. Really, this is about the human cost, because for every death by suicide, it's described in the literature that there are 6 survivors of suicide. But we know that that's simply not true. This is what the data tells us, but that's not true. Because here's a family of 4, and if one of these people died by suicide, simply in a family of 4, there are 3 suicide survivors just in this family. But I know that there was a family medicine physician that died, and his whole department was impacted, and all of his coworkers, and the people that he came into contact, and all of his patients, and all of the people that were at his funeral. And so there were hundreds and thousands of people impacted by his death. And that is the way it is for every person that dies by suicide. There are hundreds and probably thousands of people that are impacted by each death by suicide. So the human cost is enormous when someone dies by suicide. And the trouble is that when someone is facing suicide, they feel hopeless and helpless and alone. And those are the things that we need to pay attention to when we're confronted by someone who's facing a suicidal crisis. Our job is to convince them that they are not hopeless and that they are not alone. And that's our point of intervention, because that's how they feel. So what do we know about suicidal behavior? Because this becomes very important for suicide prevention. This is national data from 2015, but it also mirrors Wisconsin data. In 2015, almost 50% of suicides were related to firearms, 49.8%. Another almost 27% were caused by suffocation, so carbon monoxide poisoning in cars, as well as hangings, and almost about 15% were caused by poisoning and drug overdose. So if we can work on means restriction, we can prevent deaths, and I'll talk about that in a moment. Means matters because suicidal crises are often brief. Suicide attempts are many times impulsive with very little planning. And suicide methods range widely in how fatal they are. So we know that women die, I mentioned before, women die less often than men because women tend to overdose and they're found in time, their stomachs are pumped, and they live. Men use firearms, which are far more lethal than using an overdose. And so when someone tries to take their life by firearms, they're far more effective. So, and the other thing that we know is that 90% of people who survive near lethal attempts do not go on to later die by suicide. There was a study done by people that attempted, or that jumped off the Golden Gate Bridge, and very few people lived to tell the story of that. But the people that did survive the jump off the Golden Gate Bridge said that when their foot left the bridge, they had a moment of remorse. And so there's ambivalence to the moment of death. And so the people that survive the attempt, 90% don't go on to attempt again. So if we can interrupt the attempt, then, or stop the attempt before it's even done, we can save lives. So the idea behind this is if we limit access to firearms and medication, then we can many times stop that attempt before it starts. Now, I'm not anti-gun. What I'm suggesting is that when someone is in suicidal crisis, we can ask about firearms, and we can say, can I take your guns to your brother's house? Can I take your ammunition until your suicidal crisis is over? I'm not suggesting that we give your guns to the police, but I'm saying, can we just keep the guns safe until you're feeling better? And then when this crisis is over, then, we'll go back to hunting together, or whatever it is. We'll target shoot again. But just until this crisis passes and you feel better, let's keep you safe, because I care about you. I care about your well-being, and I want you to stay alive. Because that message is powerful, and that's how we keep people safe. Let's keep medications locked up, including Tylenol, if someone is feeling suicidal. Let's keep them safe until the crisis passes. The other important thing is that alcohol and drugs impair people's thinking. And so if someone is impaired by alcohol and drugs, they're more likely to make a suicide attempt. And so on autopsy, it's been found that up to 75% of people have been found to be intoxicated at the time of death. So we may not be able to limit exposure to alcohol and drugs. I mean, if we're able to do that, great. But again, if we can take the firearms out of the picture, then we're limiting a very lethal means of suicide. And so the firearms piece, especially in our hunting state in Wisconsin, the rates of suicide are actually higher in a rural area than an urban area, because we are such a large hunting state. Firearms are huge in our state. So, any questions? Because I know I went through that quickly, but I want to make sure to leave time for everything. So I'm going to change gears and really talk about what's most important in this room, which is physician suicide. There's a doctor, Dr. Pamela Weibel, who's become very interested in physician suicide. And some of you may know her work. She wrote an article called "What I've Learned from My Tally of 757 Suicides, Physician Suicides." She became interested in physician suicides, and she put up this website, PamelaWeibel.com, and people started writing to her. And they started sending her their physician suicide letters from loved ones, and she began publishing, putting this compilation of letters together, and she actually published a book. And she compiled data, and she started talking about the reasons why physicians die by suicide. Now, I mentioned that 4 out of 5 people in the general population that die by suicide are men. However, in medicine, it's astounding that it's 7 to 1 in medicine as to who dies by suicide. It is a worldwide issue. It's not just in the United States. And as is the case in the general population, men use firearms and women die by overdose. Male anesthesiologists are at the highest risk for dying by suicide. And I put an asterisk by this because prior to coming to Agnesian SSM, I worked for the Medical College and Children's Hospital for 18 years. And you might have seen in the media in the last few months that there was a male anesthesiology resident who took his life at Freighter Hospital. He barricaded himself in an operating room, and he injected himself with propofol. And he died just within the last few months. And so Milwaukee got national attention because of his death by injection. And so, this is a crisis. And the rate of suicide for physicians are twice the norm of the general population. So this is a silent epidemic that's happening in our population, in your population. I'm a nurse practitioner, so I speak to this to you. This varies by geography. What Dr. Weibel writes in her article is that physicians in New York will jump from tall buildings, and physicians in India will hang themselves by ceiling fans because that's what's used for ventilation in their buildings. Physicians also will mostly die in hospitals, and she states that they die where they are wounded. And so they die most often in hospitals. And that it seems that many times they seem to be the happiest people. That it will be when they're just back from vacation, or they'll be on social media giving a thumbs up after a surgery. They're the type of people that will make people smile all day long, and that those will be the people that will die by suicide. And she describes that they will suffer silently and never let on that there's anything wrong. And so my plea to you is that as our colleagues, is that we may be the ones that know that something is amiss. And so if we see signs that someone is in trouble or struggling, we may be the point of intervention, because if physicians and providers are seen as the happiest people to the rest of the general public and even sometimes families, that if there are warning signs that we're seeing, we may have the opportunity to intervene. And so we should take advantage of that. So what else Dr. Weibel describes is that you work a lot of hours, and that working 100+ hours per week, like any other human being, you develop personal problems. Working a lot of hours can lead to things like divorce and custody battles and personal stress. And that you can become immersed in your patient's pain, and sometimes you have no time to deal with this fallout, and that can compound personal pain. Also, patients die, and this hurts you. Sometimes you don't forgive yourselves, even when there's no blame, and so this compounds. There's a litany of other things, and much of it I had not enough time or space to list everything, but things like malpractice. There are productivity demands, and the system tends to blame the provider for lack of efficiency. That was actually one of the major reasons why I left the medical college. I had a health condition, and I kept getting reminders from the system about how far I was behind on documentation. And despite my health condition, my administration was not behind me and was not modifying my schedule. And I was getting farther and farther behind, and I needed a friendlier work environment. And I wasn't going down the path of suicide, but I was very burnt out and stressed, and I needed a different environment. So I certainly understand that. We have lack of confidential mental health care. Physicians and providers are hesitant to care for their colleagues in mental health, and people feel very hesitant to seek mental health care because they're worried about the lack of confidentiality or potential of lack of confidentiality. Even if it is confidential, we're worried about that potential lack. And so self-medication with substances. People will self-medicate with alcohol and other substances. And then there's the potential of medical board issues. So if you have a mental health issue, if you have a substance abuse issue, and you seek care, sometimes the medical board gets involved. There was a story on Dr. Weibel's website where there was a physician in Florida who was in front of the medical board in Florida. He had lost his license because of iatrogenic, work-induced mental health and substance issues. He had had his license pulled. He was in front of the board for a review, and he had lost everything. And they said, come back in a year for a review, and we'll take a look at it in a year. He was living in a halfway house, and because they said, come back in a year, he went out in front of the board, building in the board, and hung himself on the tree in front of the board. And it was all work-induced. But this happens because of these investigations and things that are brought on by work stress. For medical students and residents, we know about academic distress, things like being unmatched for residency, things like hazing, bullying, sleep deprivation. Now, we also know that residents' conditions are improving. But many of you lived through these things, so you know how stressful it is. So what can be done? We're all buried in a sea of paperwork. So I put together the Good Samaritan Law, and not that it applies necessarily to this situation, but it is something that everyone can relate to. You come across a car accident, and it says that if you, in good faith, intervene in a car accident, you're protected by the Good Samaritan Law, because if you act in good faith, you'll be immune from civil liability. And this was from July 2007. And what I want to tell you is that if you interact or you intervene with a colleague who's in distress, you are under no obligation to take them on as a patient. You don't create a medical record, and you're acting in good faith to just lend a hand and listen. You ask the questions, you intervene, you're acting as a friend and a colleague, and you're not taking them on as a patient. And you're just doing the right thing and intervening and possibly saving a life. And isn't that the best thing ever? It's so simple. It was mentioned that I'm a QPR trainer. This is very easy. It's called question, persuade, refer. The QPR Institute is an organization that offers lay training. So we give trainings. I'm actually doing one tonight at Waukesha County Technical Institute for people from the public that come in. It's a 90-minute training, and we teach them, if they're confronted with someone who might be suicidal, how to simply ask the question, are you suicidal? Are you thinking about killing yourself? And if they get a positive answer, how to persuade that person to get help and what the resources are for someone who might be suicidal. And it's 3 steps that the QPR Institute says anyone can learn to help prevent suicide. So, recognizing signs of suicidal crisis. Well, what we know is that when someone feels suicidal, there are changes in the things that we say and do. There are verbal warning signs. There are things like indirect things that we might say. You know, I've had enough of this. I can't go on. You know, I've about had it. I'm thinking about, you know, wanting this to be over. And so there are subtle cues that people might say that are different from how they've been. And direct things like, I'm going to kill myself or I'm going to end it all, that's pretty easy. But sometimes it's indirect, subtle things that come up that we need to pay attention to. And there are behavioral things that people will do. So in adults, which our colleagues are adults, but things like, you know, if you notice that they're overly irritable, their sleep patterns have changed. They're coming into work and they're exhausted all the time. They're starting to withdraw. So they used to have lunch with their colleagues and suddenly they're withdrawing, and you know, or they're crying all the time. I don't want to say women, but men too. And you know, overly irritable, less productive at work. You know, just hard to have a conversation with, more shut down. Sometimes the opposite happens. They'll have had a period of irritability and all of a sudden everything's peaceful and calm and they're happy and at peace and, you know, everything's great. Sometimes that signals that a decision's been made, and that's also a time to question. So everything's been really rocky, they've been going through a rough time, you know that maybe things at home have not been great, or you know, they've lost someone and you know, everything's been terrible, and then all of a sudden it's calm. That's also a really pivotal time to be asking a question, like, you know, something doesn't seem right. Are you all right? Are you thinking about suicide? What's going on here? Because that's also a sign of finality sometimes, that we should be paying attention. And many times there's situational clues. Things like a diagnosis of cancer, or losing a family member, or divorce, death. Many times, I mean, we wouldn't see this at work necessarily, but moves and big changes. Children leaving for college, an empty nester. I know with my own children, you know, when I became an empty nester, that was a huge change. But any major financial changes in the family, there are just so many potential life changes that can bring it on that we need to be paying attention and talking to our colleagues. Sometimes we work and we live in silos and we're not paying attention to what's happening in the lives of our colleagues. And so being able to have those conversations and talk about it. If you suspect there's a crisis, ask. Asking the question, you will not put an idea into someone's head. This is a huge myth. If I talk about suicide, I'm going to make them think about it. Trust me, they're already thinking about it. If someone's suicidal, you will not put the idea in their head. And that's the biggest thing that we get sometimes at QPR training, that the people are afraid of opening up that topic of discussion. This is something that is a huge myth. And ask directly, are you thinking about suicide? Has this been something that has been on your mind? And not in the negative, not, you're not suicidal, are you? Because the answer, of course, is, well, of course not. Only crazy people are suicidal. Of course not. I would never do that, because you're evoking a negative response. So there's a really good video that I'd like to show you that I think this is the key, making people feel that we are connected to them and that we are with them. is key.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space where someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. At least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So that's the whole point, is making a connection, right? And letting someone know that you're there for them, because suicidal people believe that they cannot be helped. So we have to do more. We have to be there with them. So once we've kind of asked the question and we've sort of asked them if they're feeling suicidal, then it's about persuading them to get help. So when you're with someone who's feeling suicidal and you've determined that they really do need help, then the best referral is about taking them directly to get help. So maybe it's about walking down to Dr. Christensen's office and saying, hey, I have someone here that needs some help. Or maybe it's going to the emergency department if you're at work. If you're not at work and you're outside of work, it may be making a phone call and seeing about a referral to get a therapy appointment. It may be getting a commitment. Next best referral is making arrangements to get help. But it's also communicating, I'm on your side, I'm here with you. We're making that connection. Now, because we work with our colleagues, we see them on a frequent basis. And so this isn't like doing training in the community where we're having to make phone calls and follow up, because these are people we see on a frequent basis. This also is something that doesn't need to be reported to your supervisor, doesn't have to, break confidentiality, because these are just people that we're walking with and we're showing empathy and connection to, and making that, we're linking arms with to say, I'm here for you, and I'm gonna just make sure that you're okay. If someone has thoughts of suicide, but they're not in immediate danger, they don't have a plan, they don't have intention, that just means that there's distress there and they need help connecting. It's only when there's an active plan and active intention that you have to go to the step of getting someone immediate help, getting to an emergency department. So you want to be able to sort of assess that and walk through it in terms of what is the immediate risk. But it's really just that connection and helping them feel not alone, so that we make sure that, that they know that there is someone there that cares, because that does make all the difference. So, and for you, don't walk alone. Now, this could be someone that lives alone, and you might need to ask them, who else is in their sort of village for support? Do they have extended family? Do they have close friends? Can you call their clergy? Get their primary care physician involved? Again, calling for outpatient therapy, or maybe a next day appointment with a primary care provider. So helping them get appointments scheduled, or getting other extended people involved in terms of that circle of support. Whoops. Calling 911, we teach this in the community. If there's an immediate threat for safety, obviously, that's pretty straightforward. But if there's, we also, CIT officers in Fond du Lac. So CIT trained officers are crisis intervention trained. If there's an immediate threat, crisis intervention trained officers work with people that are in suicidal crisis. So if you call and you need to, if you need to call, ask for a CIT officer. They're very good at de-escalating situations, and so you should know about that resource. And then other resources, there is a National Suicide Prevention Hotline that's available to talk to people, and so you want to make sure that when you're not with your friend or colleague that you have this information. Also, there's a text crisis line. And we have CSI's website, which is the Fond du Lac website for comprehensive service integration. So there are resources available. Questions? Because I'm going to turn this over to Drs. Schmidt and Dahl otherwise. Peripherally. All right.
Assuming I should use, is this working?
There. Okay, perfect. So basically, what we're trying to do is just to emphasize the importance of relationships. And so I thank you so much. That was an excellent presentation. I was actually near tears a couple times. So hopefully you guys have heard a little bit, because we've presented this a couple times, about where we are and what we're trying to do. We have now 2 new committees that started just this fall. So we have the System Healthy Work Committee and the Healthcare Provider Advocacy Committee. And so what these are is the System Healthy Work Committee was actually developed after we really learned how unhealthy our work is, and that we really need to do something to be able to have an ability to recognize how unhealthy that work is and how we can change it. And so the people that sit on this committee are half physicians and then half administration. So the people have actually the resources that we need to allocate funds and staff to anything kind of project that we need to do. Now granted, this is at our local Ignatian level, but SSM is interested in this as well. So hopefully this is something that will become even across the SSM regional system. The Healthcare Provider Advocacy Committee was actually the beginning of all of this, where we started talking about what we needed to do with respect to, no offense, physician wellness was the first thing that we started with, and this was where we tried to come up with a way to do something for our physicians. But we recognize this is not just physicians. This is healthcare in general. It's actually, this specifically represents the advanced healthcare providers. So we have our physicians, both employed, our clinic physicians, contracted physicians. We have our nurse practitioners, our PAs. We have a representation from chiropractic and retail pharmacy. And is that everybody? I think that's just about everybody. So it's a group of about 23 or so. We've only met a couple times, but the goal is that we're actually here to try to make a change and actually do something. And so, you want to start with this?
So there is a significant component to what keeps us from accessing care, and it's stigma. And so how do you make change in stigma? And there's a large body of research, but it comes down to some toolkits, and strategic stigma change is really where you talk about someone having something that you can identify with. So when I found out about strategic stigma change, much to my chagrin, if I'm going to be doing this, I have to acknowledge that actually one of the things I struggled with and continue to is public speaking. And so as a professional and as a psychologist, you could say, of course, that's why the psychologists go into that line of work. They always have some issue that they're trying to figure out, which is somewhat true. My brother called it a haven instead of a profession. But the strategic stigma change says, you know, I kept doing it. I just kept doing it, and my voice doesn't shake as much as it meant anymore. I still like ask everybody afterwards, how did I do? Was that okay? But it is having some recognition that even as a psychologist, when both of my parents died, I couldn't skip grieving. I had to go through that, even though I know the stages of grieving. And so if you think about our stress response, it really is the case that you're all here because you probably have incredible stress response resilience. You can handle it. You went through the pressure cooker. And so what that leads to is that myth or that idea that somehow if we have to access support, care, or other resources, that there's a chink in the armor. And so for me, one of the things about strategic stigma change is kind of normalizing the fact that it's a high stress situation. And what we're talking about is, yes, that's partly personal, right? But it's not just about buck it up, use your resiliency skills, fix it. We also know that there's these larger system issues that need to be addressed. And that's what Heather's going to talk a little bit more about. But just to know that you and your colleagues can have a relationship. You can check in with each other. It's not a sign of weakness. Say, yeah, I had a real tough code. I had something happen that I just can't get out of my head. We have resources to address those things. But it's knowing that, and it's having that conversation in the relationship and not being afraid of the stigma that I'm going to have to check a box now that says I had a mental health issue, and so I'm not going to be on a panel. So the stigma piece is really helping you understand that it's actually all of us, statistically, otherwise, and it's just a matter of a relationship and accessing the care we need. A good personal example on burnout was when I was talking to someone about sleep, I'd go see Oliver, and Oliver's always trying to tell me that, biking, country skiing. I was like, really? Can I get a higher dose of PPIs? Oh, you're on the max. Maalox by the bed is a good thing, right? But it really was when someone started talking about sleep and said, a lack of sleep is actually a self-harm behavior. And so in my profession, we think self-harm like cutting on yourself, right? And I was kind of like, ooh, I hadn't thought about it that way. How can you run the marathon if you don't have anything left to give? And think about the lives, and I think you were telling me, 1,500 at least, 2,000 lives in any of your practices. How are you going to continue to do that if you can't take a moment and leave the email alone and really balance your life to be successful and recognize your peers that are over their heads as well? You just can't do it. And that's not a sign of weakness, that's not related to stigma, that's just the fact. And so those kinds of decisions about taking the bike ride, allowing the sleep, doing the things that we can do, is that 20%. Oh, sure, I can, certainly. So the other part of what we're working on is recognizing second victim. It comes in lots of different ways. We have a reporting requirement, there's a review, there's some mistake identified and made, and so then we're left with, that shame and the stigma of having been that person in the line of the sequence of events that identified as having done that. And so that typically is something that people don't want to talk about, and they feel very badly about it. But in the end, we all do that. We all make mistakes. You need to learn from them. We recognize them. That's part of what we need to do. Creating a culture that identifies that there is a second victim and that we can respond and help that person through that is really, really important. The other part is just the sheer weight of listening. The trauma that you hear every day, the information that you have comes oftentimes with pictures in your head. As people describe that, those pictures can get locked. And so there are a lot of ways that we can help get those pictures, get that emotion, and get those things moved through. One of them is a very efficacious and evidence-based treatment called EMDR. And that can be very short term. And we have like 30 people trained in it, including our EAP. And so we also have neurofeedback, another great way to process stuff. So there's some really good evidence-based, short-term kind of solutions for things that you might not even realize that are out there. It's not like therapy and you have to go and sit and, you know, talk about things from ever in your childhood. It's like, no, I'm getting stuck on this.
So this model was actually introduced when Dr. Evelyn Schaefer had done a safe person training for our directors and supervisors. They had come forward and said, hey, you know what? We have a lot of physicians and providers opening up to us, and we don't necessarily feel prepared to deal with this. So we offered a safe person training, and Dr. Schaefer had done this. She talked about this model, this mental health continuum model, basically that at any one point of any day, we are all here. So we could be green and doing pretty well. We could be yellow and, you know, maybe we're starting to respond a little bit. We could be orange or we could be red. And so the goal is that, you know, when do people ask for help? When do you think?
Red.
Red, exactly. Do you think we could do a better job of that? Maybe we could start recognizing that if we're starting to feel a little injured or even reacting, that there's something we need to do. We need to take a step away, we need to take a day off, we need to talk to some friends, we need to, whatever it is that could help prevent us from getting to the red. So with this model in mind, the HPAC, the purpose is actually to change the culture. So our goal is to bring the meaning and joy back to work. I mean, work has become work. And so we did not go into medicine to really, you know, be miserable all the time. We went into medicine to make a difference and to actually impact people's lives in a positive way. And so the goal is that we're trying to change the culture so that people feel more comfortable recognizing A, where they are, doing self-checks and coming forward. And so they don't have to come forward to this panel, so that we don't want people to think that they have to come to the HPAC and stand in front of this group of people and do some kind of presentation. Of course, that's not what we're talking about. But, you know, calling your supervisor, calling your med staff office, calling your colleague, or just, hey, popping your head in next door to your coworker. And so recognizing that and working to really look at ourselves and look at our colleagues. We want to do more education about this. We want to do as much education as we can to help with stigma and actually help reduce the stigma, as well as working on these 4 high impact areas. So our 4 priority areas that we're trying to focus on, and as you probably read in the literature, I mean, burnout stuff is everywhere. Everybody's trying to figure it out. They're all trying to come up with their own plan. And there are models that actually work, but they don't always tell you how to implement them. And so this one is trying to, at least it's something that, this was based on Harvard. The Harvard Medical Group was working on something like this. And so the 4 priority areas are pretty important because, as you can tell, IT is probably the source of many of our problems. No, you know, we all have issues with the computer. And so, unfortunately, it's not going away, and in fact, probably in the next year, it's going to get a little more complicated. So, trying to figure out ways that we can actually optimize our workflow. There's not so many clicks that we have to do, and maybe we need to actually have some help with that, and that's okay. And so we do have a provider liaison. She is specifically meant to work with the healthcare providers with respect to IT issues, but she's pretty busy, as you can imagine, and she is getting pulled in other directions because she sits on a lot of committees because everything that gets done with respect to IT, she's trying to keep a provider perspective. And so we would love to have more of her, because, you know, she's got a pretty good role, and if anybody's gotten to work with Tiffany Rowe, she can actually change the way things are done. And very quickly, and it makes a difference. So work design's another one. So we've actually had a group working, Dr. Colmenares and Mike Dries have been going out and offering different best practice solutions that you can use for how your workflow is in your clinic. There's a list of these, things like pre-visit planning, there's a nurse practitioner that's specifically around to do Medicare wellness visits. There's nurse practitioners that are working in the nursing home so you don't have to see your own patients. I mean, there's a lot of different things that I haven't even, inbox management. So there's a list or a menu of options that can be offered that if we're not doing them, we are definitely drowning. And if you're doing some of them, it can help you, and you might want to do 1 or 2, or you might want to do all of them. But it is something that we have available, and I think that right now, at least Mike's going from practice to practice and working with people. So that's something that if you are interested in learning more about that, then you can certainly reach out and let us know. Governance, so communication is always important. So we want our voice to be heard, right? So, and right now, I feel like we get our voice heard pretty well here, and then we have to think about how things are going to change in the near future, about whether our voice is being heard at a higher level. And so it is something that we want to make sure that it's constantly at top of mind, and that people are making decisions with providers in mind, and kind of thinking about that end result and that end user. And then finally, well-being. So this one is, of course, my world. I love wellness stuff. And so this, of course, is resiliency building. This is working to build relationships, foster relationships. What we envision here is as many caring touch points as we can possibly get. Whether it's one-on-one, whether it's in small groups where we meet together and actually have a meal. Maybe it's actually working with more departmental things. You know, we have this great Fond du Lac County Medical Society that I don't know how many people go to these meetings, but it's great. I went the other night and I got free dinner. Because I know you got a free glass of wine. So, so it's something that I think we should promote. And so there are these social things that people do, and there are a lot of different hobbies and interests that people do that if you're new to town, you might not know even exist in this community. You know, it's a smaller community, can maybe be viewed as a little cliquey. So if you're new, you might need to actually have some help navigating that. And so that's what we envision here, is actually having a peer mentor program, having people that kind of step in and take you under your wing and help you out, okay? So when we think about back to this model, this really starts to think about these three first areas. So our healthy, our reacting, our injured. This is the prevention. These are the people, and the work we want to do is prevent ever needing to get to the red, okay? And so, so that's the primary area. So things that you think about, like maybe you have an idea for your clinic that you've been doing that has really streamlined your workflow, it's helped you, and you think it's worth sharing, hey, bring it forward. If you think, gosh, I need help with streamlining my workflow and I really could use some help, then ask. It's okay, we're here. And then, you know, what if you are feeling overwhelmed, or you feel like a colleague's overwhelmed? Certainly, these are the people that you can come to if you aren't sure how to navigate that. If you don't feel as comfortable, even hopefully you feel a little more comfortable after Tammy's presentation, but if you don't feel as comfortable, then certainly if you come to anybody on the committee, or even just come, you can come to me, you can come to Matt, then we can help you navigate that system. And so, you know, so these are just some examples of what this age pack is for. Now, there's a difference between this and the Practitioner Health Committee. So Practitioner Health Committee, I believe, is mandated by a Joint Commission, is that right? Well, yeah, yes, Joint Commission. So every hospital system has to have a Practitioner Health Committee. This can have the negative I guess, impression that this is more punitive, that you are impaired or you are ill, and that somebody is trying to take away your license, or they're trying to get you fired. So basically, that's what, unfortunately, this committee can have this negative look, which it's not meant to be, right? It's meant to actually prevent needing to go down disciplinary actions. But unfortunately, at least here, I think that the impression, connotation, is that it has this negative connotation here. So this is more the ill. So these are the people that are in the process that they are potentially causing harm to patients or harm to themselves. This is where we need to make sure that we are, if you're concerned about somebody, that this and it's a valid concern, certainly make sure you're bringing this forward. So, but that is, we're trying to really create a culture so that we don't need to get there. And of course, there's other reasons you get there besides just burnout, but that's the goal. So from an SSM perspective, so I've been talking to the regional, there's a regional board subcommittee that's hopefully going to be approved from SSM in St. Louis soon. That's the People Subcommittee. And the goal is to actually look at engagement and well-being for clinicians and other staff, all employees, as well as looking at leadership development. And so they have been, in their process, they've been working on this too, and they're really interested in the Stanford model. The Stanford model is that, I don't know if anybody's familiar with the Stanford models. Anybody seen this before? So basically, it's very similar to what we're talking about, but this is what they call their WellMD professional fulfillment model. And this is the compilation of AMA research, the Mayo Clinic research. Stanford has now hired Tate Shanafelt. If anybody's read any of his work, he came from Mayo, did basically the bulk of all the research on physician burnout, and he is now their chief wellness officer. And so they are doing trainings. They have a whole website that is talking a lot about this, but trying to promote this type of a concept. So the culture of wellness, the personal resilience, and the efficiency of practice. So what's good about this is it's still recognizing that it's not our fault. It's not on our shoulders to make a change and to do yoga and to feel better and to just suck it up and deal with it. It is actually really looking at a whole well-rounded model. The goal that we are doing, at least or we've had a few discussions about it from the SSM level, is that this would be personalized. It wouldn't be exactly this model, but it would be a compilation of even what we're doing here, and then what this model, this is a nice vision, it just doesn't tell you exactly how to do it. And so, so that is where we are so far. So, this is my favorite quote, and so I end pretty much everything with it. But really just back to that whole idea of relationships and that people start to heal the moment they feel heard. So, do you have anything else to add?
Breathe.
I know.
No, I meant not you, I meant all of us. Because I think one of the things, but you did really well. Thank you both. I think you can come up and we can do questions. But the thing do you even take that moment, right? Do we take the moment to do a belly breath, right? Just breathe in, diaphragmatic breathing, hold it for 4 seconds, release, and breathe again. If you do it, it works. It just resets our stress response. But how often during the day do you actually take the moment to breathe? And so that stress level and that stress response is something that we can intervene on. And I think that when you think about reaching out to each other, it's simple. It's just how you doing today. And so all of the things we talked about are within our reach, but we also know that we have a lot of work to do. And so are there any questions for us or things that you'd like to ask or talk about? No stigma.
Well, I didn't interact every day with Dr. Whitmore, but I saw him on a regular basis, and I didn't see anything coming. And we talked about warning signs here today, and he just didn't seem burnout or shocked me like everybody else.
Yeah, and I think that's one of the challenges, is that there are those times where we just won't. And the guilt that's associated with post-success, well, and not when you use the right word, but when someone commits suicide, is that there were something that we could have identified, should have, could have, whatever. And that's really the impact. And in reality, there were lots of opportunities, but there were a lot of things going on, right? And so some we know, some we don't know. But I do think having those touches, even further towards the yellow, times when life events occur that we're not aware of, or following up, and just being connected to other people is really what the challenge is when you're working 100+ hours a week, right? And so I think that from my perspective, it's that we can control. We can reach out, we can say hi, we can check in. How you been feeling? How's it going? I know you had a tough situation with that. Those little touches are really what the research shows as being most helpful. And I think the ethos, the idea that we're trying to break down is needing that or reaching out is the relationship. And so as committed and successful and high stress tolerant people, how do physicians break that down and really be kind of with each other for periods of time when we got to get going?
So I actually had a personal experience when I was in residency. One of my very favorite patients, she had struggled with depression and anxiety, had just had a baby, but she was doing better, right? So she had a complicated delivery, complicated by cholecystectomy, the whole thing. And I, as a third-year resident, had seen her, and she was doing great. Like, she really was doing great. And then I found out that she died that night of a methadone overdose, and I was like completely devastated. And she was one of my favorite patients. She had these little babies. I had just delivered her baby for her. And it I think has stuck with me because she was peaceful. And I think since then, it's really just been that calm before the storm or whatever it is. But when you talked about that, it's still, I mean, that was 12 years ago or 13 years ago, and still just really affects me, like, you know, physically. I could still cry about it. So, and I didn't know Dr. Whitmer very well, but I had seen him 2 nights before, and he was making jokes and laughing, and, you know, from what I knew seemed normal. But I had guilt, and I didn't know him very well, but I still had tons of guilt about not doing this soon enough, not making a difference. And so I think, unfortunately, his situation has really prompted a lot of thought and a lot of purposeful change. And I mean, my hope is that we never have to deal with this again.
Yep.
So I have 140 people that report to me. And just this week, we had a very close near miss. And I interact, I check in, I do all the things that I think I'm supposed to, but it was a colleague that person shared with, and fortunately was able to do QPR, and we had a very better outcome. It could have been an empty chair. So I don't know that we're always going to know. We have things to look for, we always have those kinds of things, but I do know that culture, that ability, that reaching out to a colleague, that's really what we have to do for each other, and I think that's sort of the whole point. There's no one way to do this right. But self-care is a big part. You can't minimize that, but it really is the relationships.